This evening, I'll be speaking on coronary artery bypass in stable coronary artery disease. I'm the only here amongst a group of lions at a time when a few years ago, most cardiologists were writing obituary on coronary artery bypass surgery. So it's my privilege to speak on this topic, especially my talk follows Dr. Fayyaz Shaul, whom I met 25 years ago in Mumbai when a conference was organized by Dr. Samuel Medwiz. Stable coronary artery disease is generally characterized by episodes of reversible myocardial demand supply mismatch related to ischemia or hypoxia, which are usually inducible by exercise, emotion, or other stress and reproducible, but which may be occurring spontaneously as well. Why is coronary artery bypass better than PCI? So I thought, let's strike where it makes the biggest difference. PCI treats an isolated lesion in the proximal part of the vessel, where the disease is most pronounced. As against coronary bypass, bypasses the proximal 2/3 of the vessel, where the current lesion and future threatening lesions occur. That means we are operating at a site very unlikely to get disease over the next decade or more than 2 or 3 decades at times. This advantage of coronary surgery will persist even if stent restenosis is zero, and this, ladies and gentlemen, to my mind, is the basis that coronary artery surgery is here at least in the foreseeable future. If you go through the current guidelines, I can just summarize in one sentence this complicated looking slide. More extensive the disease, then class 1 is the recommendation, and level of evidence is class A for coronary artery bypass surgery, which means angioplasty is very good when the disease is mild or with low syntax scores. But when the disease is extensive, coronary artery bypass surgery continues to give superior outcomes. Coronary bypass is time tested and in fact is the most studied procedure in the entire field of medicine ever. The subset of patients that we treat is different to that the cardiologists treat. Our patients have obviously more complex coronary anatomy, more often than diabetics, more often than not small caliber diffusely diseased vessels, and more often than not we struggle when these arteries are 1 millimeter in caliber trying to put arterial grafts, and to surprise, most of these grafts continue to remain patent at least for a decade or more. Sadat Raza examined data from 57,000 patients who underwent primary coronary artery bypass surgery between 1972 to 2011. The results of the analysis showed that internal mammary artery graft patency was stable and similar in patients with and without diabetes at 90 to 97% at 1, 5, 10, and 20 years, and in patients with diabetes and 93 to 96% in those without diabetes, respectively. Similarly, saphenous vein graft patency has been documented until 20 years. Yes, over a period of time, saphenous vein graft patency does decline because they all get disease eventually. Most of the studies which we present and see or read are actually involving operations where 1 IMA and 2 or 3 veins was the standard practice. 1 IMA and 2 or 3 veins is not the operation that is being performed in the last 20 years. In my practice, less than 3 to 5% of the patients get 1 IMA and 2 veins. In fact, over 95% of our practice, and I'm sure that's true of majority of the surgeons, most patients in our country get more than 2 and frequently 3 or 4 arterial grafts. Similarly, radial artery patency has been documented, especially from my parent institution, Royal Melbourne Hospital, and we are very proud that radial artery patency is only marginally inferior to IMA patency. This is how a graft on the left side is a lemur to a LED. See how diseased the LED is, yet this surgery was performed 24 years ago, and look how beautiful the IMA looks. It has genuinely grown. The graft on the right side is the radial artery graft, again at 24 years. This was amongst our first radial artery graft patients. Coronary bypass surgery versus PCI, pros and cons. As far as coronary surgery is concerned, excellent relief of angina, significantly reduced reintervention rates. It tackles complex anatomy better than angioplasty. Completeness of revascularization ensures long-term survival. Mortality benefit in selected group of patients, especially if it is extensive disease. Potential high cost to start with, but over the 20-year period, the cost doesn't matter. And of course, the only drawback is coronary bypass surgery is very, very invasive, especially when the patient has 2 IMAs plus radial artery. As far as the angioplasty is concerned, initially it is very cost effective, quick recovery. You are guaranteed to go back to work in the same week. Reduced immediate complications, virtually non-invasive. Of course, it has 2 disadvantages: increased risk of restenosis and repeated revascularizations, both in the short and the long term. What about comparison of these 2 revascularization strategies in patients with multi-vessel disease? As far as PCI is concerned, it is less invasive, shorter hospitalization, low initial cost, can be easily repeated, and very good relief of symptoms. PCI has the disadvantage that there is always a significant chance of restenosis, though the restenosis rates are falling. There is very high incidence of incomplete revascularization, meaning cardiac events continue to happen. Relative inefficacy in patients with severe left ventricular dysfunction. The LV function doesn't seem to improve in patients who undergo PCI with poor LV functions. PCI has less favorable outcomes in diabetic patients, and in certain situations it cannot be performed. Whereas coronary artery bypass surgery, very good relief of symptoms. It does improve survival, especially in patients with poor LV function and with very extensive disease. The operation has the ability to achieve complete revascularization, which results in long-term survival. And of course, the big disadvantage is it has significant morbidity, significant mortality in the hands of the average surgeon, and of course is very, very invasive. So this is what I call is the fight between the surgeon and the cardiologist. And I believe the present equation is what is shown in this diagrammatic representation, though the PCI spectrum seems to be improving daily. So this is the present scenario, and this is what the PCI guys can achieve in the next few years, and we got to defend coronary artery surgery. So there are many observational studies. Recurrent events, including angina pectoris and the need for repeat revascularization procedures, were more frequent in the angioplasty group than the CABG group. And this is because of incomplete revascularization and a significant chance of restenosis in the PCI group. Again, impact of coronary artery bypass surgery on survival. So when it comes to impact on survival, there is no difference between PCI and CABG when it is involving patients who have only mild to moderate disease. However, patients with left main coronary artery disease and extensive triple vessel disease, especially involving proximal LAD, coronary artery bypass surgery definitely has a positive impact on long-term survival. Plenty of trials comparing angioplasty versus bypass surgery, and the only thing that seems to emerge is the need of repeat revascularization in PCI group. Otherwise, nothing much to choose from. Stenting versus surgery for multivessel disease, New York State Registry, 3-year survival. And again, if you see, more extensive the disease, better are the outcomes in the CABG group compared to the PCI group. So triple vessel disease with proximal LAD obviously fare much better with bypass surgery rather than with PCI. So CABG, all the things going for it are long-term morbidity, obviously better. Mortality rate, especially in the hands of good surgeon, quite low. Need for repeat revascularization is significantly less. And of course, treatment of complex anatomy is possible. And if the surgeon has intention, complete revascularization, it will impart a good long-term outcome. And over a 10-year period is more cost-effective than PCI. So I can keep going on and on because most studies that I'm likely to quote are going to favor bypass surgery. So I'll just skip this part. So in this study, if you see freedom from revascularization, obviously the bypass surgery is far superior to the angioplasty group. Similarly, freedom from all causes death favors is more or less same at the follow-up. And of course, freedom from MACE is significantly superior in favor of bypass surgery than PCI. Overall, at 5 years, 26.9% of CABG and 37.3% of PCI patients reached complete composite endpoint of death. If you take the syntax study, it clearly shows that all the factors, including all causes, mortality, myocardial infarction, repeat revascularization, and safety endpoints all favor bypass surgery. Only the stroke is in favor of PCI. What about MACE events in the syntax study? Again, if you exclude the less extensive disease, as is in the first graph, the lower two, the intermediate syntax score, meaning 23 to 32 and above, clearly favor CABG over the PCI study. The syntax conclusions are the primary endpoint in this non-inferiority trial for PCI was not met. Overall, MACE higher in the PCI group due to an excess of redo revascularization in the PCI versus the bypass group. Comparable safety outcomes in CABG and PCI at 12 months. Rates of symptomatic graft occlusion and stent thrombosis were more or less same. Significantly higher rates of stroke in the CABG group, which is understandable. And of course, syntax score will help us stratify patients who are appropriate for a particular revascularization strategy. The largest benefit from CABG seems to be in patients with diabetes mellitus. The results of this trial also suggest that patients with left main only, left main with single vessel disease, and non-diabetics may do as well with both CABG and PCI, although the trial was not powered to study these differences individually. So I can keep going on and on, but most studies seem to favor bypass surgery. In this, this is also part of the syntax study. And if you can see the bottom on the right-hand side, you can see all these criteria favor bypass surgery. There are only two criteria which favor the PCI group. One is, for some reason, the black population in the United States, and of course, patients with renal dysfunction. They favor PCI over CABG. The Nobel trial, major adverse cardiac events occurred with a frequency of 19% in the CABG group in comparison to 29% in the PCI group. The hazard ratio associated with this difference was 1.48, confidence interval exceeding the limit for non-inferiority. CABG was thus concluded to be superior to PCI. At 5 years of follow-up, CABG had an all-cause mortality of 9% versus 12% in the PCI group, 2% versus 7% for the non-procedural myocardial infarction, 10% versus 16% for any revascularization, and of course 2% versus 5% for stroke. So this study concluded numerous studies have demonstrated that the survival advantage of CABG is realized in the long term, and this has significant implications for the design and interpretation of contemporary randomized trials that seek to compare CABG to PCI. The STITCH trial, of course, showed no difference between the optimal medical management. The take-home message is bypass surgery is the gold standard in stable triple vessel coronary artery disease. Long-term results are better with CABG. No study has proven superiority of PCI. CABG is the best option in the following subset of patients: complex disease, as demonstrated by syntax trial, in diabetics, and of course diffuse disease vessel. Decision regarding the strategy, which patient gets which, a heart team approach perhaps is the need of hour. Thank you very much.